The problem in 2011 is that too many of us still use a solely doctor-centered style. And the reason is not that we're bad doctors, but probably that our mentors only use a doctor-centered style, and since we look up to them, we're going to do what they do. And they don't use patient-centered skills because they never learned it in their training. So we need to be the vanguard. Today's residents and young faculty, and some of us older faculty, need to kind of move the field forward to take advantage of those benefits. This is not just touchy-feely and more humanistic to use patient-centered interviewing skills. It actually makes you a better doctor. We interrupt our patients prematurely, an average of 21 seconds into a visit. We're on the first of a long line of closed-ended questions. When we do that, we fail to address the patient's concerns, and we fail to really understand the patient's full agenda for why they're seeking health care. When we do that, we ignore personal information because it never comes up, and the patient feels, she didn't listen to me. Because we ignore personal information, we don't get to the emotion that a patient has, so we don't use empathy, and the patient says, she didn't understand me, she doesn't seem to care about me. And then they're not going to take the medicine we prescribe, they're not going to do the exercise we think they should do, they're not going to do the procedure that we recommend. And this causes lots of problems in our healthcare system. So, patient-centered interviewing is born of some tenets, some grounding, most of which has come from the research. Patients do not seek healthcare only because of a symptom. That's really remarkable because in the biomedical model, we would only think patient has back pain, he goes to the doctor for treatment of his back pain. But it's not that simple, it's more nuanced. In fact, it's often the personal context of a symptom that makes a patient seek out health care. The patient, for example, might have a medium amount of back pain, but because he works on a loading dock, that back pain's preventing him from doing his work. And so it's not so much the back pain, but how that back pain's affecting his life that makes him see the doctor. Sometimes the symptom or that personal context creates an emotion, and it's the emotion that really makes the patient seek out health care. So maybe that young man who's not able to do his work on the loading dock is worried that he's not going to be able to keep up his mortgage payments on his new house that he bought for his family. And it's that worry that actually makes him see the doctor. And if that remains invisible to the doctor, that patient's back pain is not going to do as well as if the doctor addresses that. In the ambulatory setting, and I'm sure all of you have figured this one out already, patients usually have more than one problem, right? You've probably all been bitten by the oh, by the way, doctor issue at the end of the visit. I used to get that all the time. What we also know from the research is that the first issue the patient mentions is often not the only one and often not the most important one. So it really speaks to the importance of figuring out the patient's agenda before we launch into any one problem. We also know from the literature and from common sense that allowing the patient to tell his or her symptom story is diagnostically helpful. Way back in 1910, Sir William Osler said, "Listen to the patient, he's telling you the diagnosis." Patient-centered doctors get the right diagnosis more quickly than doctor-centered doctors. So this is really powerful research. Allowing the patient to tell his or her story is therapeutic. How many of you have ever had a bad day at work and on the way home call your mom or dad or partner or best friend or college roommate just to vent? I've done that. Anybody else? Yeah. And the person on the other end of the phone can't fix anything that happened today, right? They can't fix it. They can't cure it. But what they can do is be good listeners and say something empathic like, wow, that really sucks, which can be very empathic, right? It's communicating understanding. And at the end of that phone call, I feel better, even though nothing has changed. We can do that with our patients too, especially when faced with the unfixable. And indeed, patients don't want us to fix everything they tell us about. This is an amazing epiphany. Patients sometimes tell us things simply so that we know and can reflect our understanding back to them and be empathically connected. Lastly, patients do not experience our caring and compassion until we give voice to it. Because of pain, because of fear, because of the disempowerment that being a patient entails. Our depth of commitment, the long hours we work, the sacrifices we've made to get to this point are not interpreted by our patients as compassion. What is are the words we use and the way we say them, and that's what we're going to be working on today. There are intermediate health outcomes that we can and our patients can enjoy the benefit of. For example, improved patient recall. Patients remember more of what we told them if we're patient-centered. Improved medication adherence, which can't be but a good thing, right? If patients take more of the meds we want them to be taking. Interestingly, too, there are doctors who are patient-centered in their communication order fewer tests and fewer consults than doctors who are simply doctor-centered. This saves money to the healthcare system, and it doesn't decrease quality of care because actually patient-centered doctors experience higher quality of care than doctors who are solely doctor-centered. I call those ultimate health outcomes. And studies have shown, for example, among hypertensive patients, among patients with peptic ulcer disease, symptoms resolve faster. Hypertensives have better hypertension control if the doctor is patient-centered. We're not talking about if the doctor chooses a better medicine. We're talking about how the doctor interacts. Diabetics, in a recent study just this year, have lower hemoglobin A1C and lower LDL cholesterol if the doctor is patient-centered and more empathic. Pretty remarkable that the way you are could have such an important hard health outcome. There are social outcomes that we can enjoy and our patients can enjoy if we're patient-centered. Less doctor shopping, lower risk of medical malpractice suits. Now that should get our attention. There are 4 studies in the literature that look at why patients sue doctors for malpractice. And in each of those 4 studies, believe it or not, patients don't sue doctors because of malpractice. They sue doctors because malpractice occurred in the context of a poor doctor-patient relationship. And in each of these papers, poor is defined as the patient saying, he didn't listen to me, he didn't understand my point of view, he didn't seem to care. So the inevitable error happened, I'm going to get that guy. On the other hand, if the patient feels heard, feels understood, and feels cared for, when the inevitable error happens, the patient is much more likely to forgive. Interestingly, too, patient satisfaction scores are increased if the doctor's patient-centered. And finally, and this has been alluded to in a couple of talks already, doctor satisfaction is increased if we are patient-centered. Understanding our patients at this more humane psychosocial level, not just the biomedical level, allows us to have a sense of more meaning in our work and more connectedness with our patients. And when patients provide from time to time some positive feedback, I feel better just having come to see you. I think it really reawakens and reinforces the reason many of us wanted to be doctors to begin with. The model we're going to be talking about today was developed by Bob Smith at Michigan State University, and it's been shown in randomized controlled trials to actually lead to improved patient satisfaction and psychosocial outcomes. Let me walk you through what an encounter would look like, inpatient or outpatient, using this model. So like any encounter between 2 individuals, it begins with a beginning, where we greet the patient, we set the agenda for how we're going to spend our time together, and then we use patient-centered skills to draw out a narrative, a story of the patient's chief concern. In other words, the HPI in the patient's own words, without us injecting our own closed-ended questions about it. Then we transition to the middle of the interview, where we use those tried and true and important doctor-centered skills, primarily closed-ended questions, to flesh out the HPI and then get the PMH and the rest of our database. But we need to remember to return to a patient-centered stance if needed. So for example, I teach the medical students medical interviewing at Yale, and I might be watching one of them interview a patient, and in the middle of the social history, the student says, "So how old's your mom?" And the patient heaves a great sigh, and the head hangs down, and a tear forms at the corner of the eye. And I'm sitting in the back, hoping to God that they don't ask next, "How old's your dad?" Right? That they recognize that there's an emotion here, and that they better deal with it. All right? That's really important. Then we examine the patient and end with education and counseling. In the beginning of the interview, we use patient-centered skills to draw out this critically important psychosocial data, but also, as Osler told us, critically important diagnostic or symptom data. In the middle of the interview, We're focused more with doctor-centered skills to generate our routine symptom database, but there's also important psychosocial information that's available to us. Our job is to synthesize those two information streams, if you will, into a unified biopsychosocial story. Doctors who only do the blue part of the interview have been shown in the research to fail to elicit 94% of relevant psychosocial data on their patients, data that would be important for diagnosis or therapeutics. So it really makes us more scientific doctors to include some patient-centered interviewing into our skill set. And what's exciting about this model that we're going to be using is it recognizes that none of us have a lot of time. And we're not talking about psychotherapy here. We've got a lot of biomedical work to do. So this model can be done, once you learn it, in about 10% of the talk time. And I find that the better I get with the red part of the interview, the shorter the blue part of the interview is for me. Patients are capable of telling you information you need, and you get it more quickly without having to ask a long list of closed-ended questions.
So the first step, which is going to seem like very basic and something that we all already do, it's just about being mindful and aware of what exactly the skills are basically first to welcome the patient, to use the patient's name, and obviously this is also a moment to clarify how the patient would like to be called, by their family name, by their given name. To introduce yourself and also your role. So to say, I'm the night float, or I'm the attending physician of record is very helpful to the patient, since we are all part of a team. To ensure the patient's readiness and their privacy. So this is fairly obvious, but if you just notice that somebody doesn't have teeth, to make sure they have their dentures in, if they appear to be hard of hearing, that their hearing aid is on, that they have glasses on if they are having a difficult time seeing you, and also, of course, that they're not in the waiting room when you're talking to them. Then to remove barriers to communication. So specifically, there's been quite a bit of data that shows that patients who are getting interviewed while on the exam table feel exposed. So especially when the doctor is sitting down below them. And the same goes from a different perspective when the physician is actually standing above the patient. So to get on an even playing field is important. That can be a barrier for people that we don't often acknowledge. And finally, to ensure the comfort and ease of the patient, which is really, there's no script for this, so that's why it's not really written into the card in detail. This comes from your own personal style, talking about the weather or about a family member that you happen to know about in that patient's life that's important. And as I said, this is no more than 30 seconds. It's extremely quick. You can do it in even less than that if necessary. And then you get to step 2, which is essentially assessing the chief concern, not chief complaint, right? Because that's part of patient-centeredness, it's a concern, and agenda setting. And this should take no more than a minute. And really the goal here is to get the list of the patient's concerns and also express your own needs as a physician, and set a mutual goal of what you're going to do over that short period of time together. So this is probably the first potentially heretical thing that's part of this model. How many of you guys actually indicate the time that you're going to spend with somebody before you interview them? This is a very challenging idea for many of us to get our heads around, thinking that this sounds rude, that this could actually potentially break the rapport with patients. But actually, it's been shown to promote rapport with patients and with ourselves, because we actually clarify how much time we have in a very joining, partnering way, and make clear that we have a certain amount of time. And it's actually shown that patients who are told how much time that they will have with their physician are better able to organize and prioritize, and over time are more activated. So a way that you might frame that, an easy way is, Mr. Jones, we have about 20 minutes together today, so we're going to talk about 1 or 2 of the most important things on your list, and we'll go from there, and the rest of the issues that have come up, we'll see each other soon. And I would also just say that if an issue has come up like bright red blood per rectum in the clinic, that the doctor does have the authority to say we need to deal with this issue today, even if the patient doesn't say it. And then you need to indicate your own needs. So as a doctor, I need to go over your glucose log today. I need to review your lipid panel with you. And then you get to the list of the patient's issues. And this is particularly important to think about as a process. And I know it says only 60 seconds, but you can actually really make this efficient as you practice it. So the idea here is to ask the following 2 words at least 3 times in the first 2 minutes. And this has actually been well studied. And those words are something else. So basically, the patient comes in and they say, I have abdominal pain. Instead of launching into talking about the abdominal pain, is there something else you'd like to talk about today, Mr. Jones? And Mr. Jones is silent. And you say, well, I need to make sure we talk about your cholesterol panel. Is there something else you'd like to talk about, though? Anything else coming to mind? And to ask that repeatedly until the list is exhausted is essential. And in addition, just asking, and I would just write this on your card if it's not already obvious, but to make sure that you also ask somebody to give you a list of what prescriptions they need refilled, and also if they need forms filled out as part of that agenda is essential for time management. And finally, there's the negotiation piece, which we're going to practice when we get to skills here. This is complicated, but this is really a mutual discussion and decision-making process in which you and the patient decide on the top items that you'll talk about on that particular encounter.
Hi, Mr. Talwalker?
Yeah, J-Deep is fine.
Oh, great. Hi, J-Deep. My name's Auguste Fortin. Here's how you spell it, because I know it's not a very common name.
Nice to meet you.
Nice to meet you as well. I'm one of the medicine residents here, and wanted to welcome you to the clinic.
Thanks.
Yeah. Any trouble getting here today? Except for the microphone. So, any trouble getting here today?
Well, that's what I want to talk to you about. I normally would have walked here. I don't live that far away, but I'm having a little bit of difficulty, so
okay. Well, I
took
want
a cab.
Okay. I want to hear about that in just a second, but I wanted to let you know this is a residence teaching clinic, so you and I are going to talk, I'll examine you, and then I'm going to step out and talk to my preceptor, who's one of those supervising doctors, and then either I'll come back alone or we'll both come back and we'll have a plan for you.
Okay.
Does that sound okay?
Yeah,
Great.
absolutely.
Because you're a new patient, they've given us about 30 minutes together today, and I'll want to obviously ask you a lot of questions to get to know you and, as I said, examine you. But first, I'd like to start with getting a list of the things that you want to talk about today. So tell me what's on your list.
Well, the main thing that I came in for is my belly has just been really hurting for the last couple of days.
Okay.
It's this pain that I'm having
Right
in here.
there. Well, that sounds important. That sounds really important. I'm sorry to interrupt you.
Yeah.
I want to hear more about that belly pain in just a second.
Okay.
But before I do, is there something else you also wanted to talk about?
Well, the other things aren't nearly as important, but I wanted to see if I could get a refill on some medications that I've been buying over the counter just for cost saving.
Okay. So we got the belly pain and some medication refills. Do you mind telling me the name of the medicine, just so I know?
Ibuprofen,
Okay.
Advil I've been buying.
Okay, great. So we've got the belly pain and you'd like an Advil refill. We can certainly address both of those. Was there something else?
No, that's really it. I really want to get a handle on this pain because it's the main thing that's bothering me.
Okay, that sounds important. We'll just time out there because we're done. And that was 2 minutes, okay?
So first you're going to start out with open-ended skills, which are basically non-focusing and focusing. And the whole point of this, by the way, is to get the patient to speak in their own words in the way that they want to speak. So tell their story in the way that they want to. The idea here is that in the non-focusing realm, that you are just listening to the narrative thread. You're letting it unfold. You're not intervening at all. You're doing this by silence. Of course, not to an extreme where the patient feels uncomfortable. Nonverbal encouragement, so very connected eye contact, a sympathetic gaze, sitting like you saw Auguste sitting, open stance, hand gestures to try to encourage the patient to continue. Neutral utterances like uh-huh, mm-hmm, of course ones that sound authentic to us. And then continuers, which aren't written up here, but tell me more about that headache. That's another non-focusing skill. Focusing, on the other hand, is getting the patient to focus in one area that they already brought up. And I want to just say that again, that they already brought up. This is not you asking other questions. So let's say that the patient said, somewhere in the course of the interview, I suspect that these headaches that I'm telling you about actually are connected somehow to my arguments that I have with my wife. So if that's at the beginning of the interview, then you might echo back, echoing is the skill, headaches. I heard you say headaches. If it's more at the end of the interview where rapport was already built, then you might echo back to them arguments with your wife. Does everybody get the idea? That's kind of what echoing is. It's using the patient's words and saying them again to try to prompt further discussion. Requests are literally, tell me more about X, about this particular issue that you're describing. And summarizing is very similar to the summarizing that was used this morning by Dr. Fader. It's basically higher order echoing. So it's like, this headache that you have seems to be very much, you seem to describe that this headache connects to the arguments that you're having with your wife, and basically bringing it all together. The next set of skills that you're going to need to practice today and to think about are really in the relationship building realm. And those are emotion seeking and empathy skills. Here what you're doing is you're basically trying to draw out the patient's not just symptom story, but their personal context and their emotional context for why this matters to them, and then to be able to empathize with them in an effective, systematic way that you can do with anybody. So in terms of emotion seeking, there's direct and indirect ways of seeking emotion, right? Most of us experience this all the time in our interpersonal relationships, right? Our personal lives. So direct is literally, how does this make you feel? But if somebody's actually crying, if they're actually emoting, then this also might take on the life of, well, I can see this is really difficult for you, and tell me about that. So it can also be a little bit more explicit in that way. On the other hand, as many of us encounter, I'll speak for myself, as I encounter on a more regular basis than not, I don't get anywhere with direct emotion seeking with many of my patients. And so indirect skills, I think, are very useful, and I just wanted to bring them up for a minute. And this is stuff you can practice today. So first of all, impact. What is the impact of these chronic headaches on your life? Belief. What do you think might be causing these headaches? And this is actually an interesting question because it may get at the distance, potentially, in many contexts, but the cultural distance between the physician and the patient. And that could be really fascinating to navigate and important. Triggers. So why today did you come in with this headache when you've had it for 6 months? And this is particularly important, as I've personally learned, because what happens is that oftentimes we are so busy and so stressed as patients that we are unaware that our stress in our life of some sort, some acute stress that's occurred, is actually connected to a somatic concern. So this very question can actually help people connect to what really brought them in to the doctor's office and can be extremely time-saving. And finally, self-disclosure, which you have to be careful about how you use this, but the idea is I can imagine how upsetting that could be. I could imagine having felt that way myself. So now that somebody's actually hopefully expressed some emotions behind what they've experienced, we also need to empathize, and so there's a mnemonic. How many of you guys have heard of NURSE? This is a great mnemonic for literally expressing empathy in any context, in this context in particular. So first, to name the emotion so the patient knows that you heard, and this should all be written out on your card. Then to express understanding, that you truly understand the patient's plight or literally where they're coming from in some way. And this has to be stated explicitly. And then to state respect and support, that you are truly there for the patient and that you very much respect the challenge that they're encountering. So now we get finally to steps 3 and 4. You're really only spending 30 to 60 seconds, by the way. This is quick. So the idea here is that you're going to use these skills to elicit the entire patient narrative, not interrupting them as much as you can, and not bringing in the doctor-centered perspective at all. This is not part of this model. So the goals here are to gather important information, elicit emotional expression, and then express empathy. The methods, I think, are going to be fairly clear, but you want to just get the patient to talk about what they want to. And then the challenge, though, as I think I already said, is resisting that temptation to delve into the differential. And literally, you may have to sit on your hands to prevent yourself from doing this. So first, you're going to use an open-ended beginning statement or question. So this is now leading into the HPI. So you said before in your list of issues that you want to talk about your headache. Let's start with that. Tell me about your headache. Then to use non-focusing open-ended skills, and we've described those in great detail, but just to remind ourselves, silence, neutral utterances, and nonverbal encouragement. And then in addition, to obtain additional data from nonverbal sources, and I think I'll just bring your attention, most of this is fairly obvious, but I will bring your attention to the last line here, which is the line that we neglect very frequently, which is the self. And to say that if you're feeling really sad with a patient in these first 2 minutes of your encounter, there's a distinct possibility that they may be depressed. And so that is part of the additional data that needs to be collected by the resident physician and by the physician. So then we get to step 4, which is a continuation of step 3, and this really is the crux of it all. This should not take more than 2 to 4 minutes. This is quick when done effectively. Your goal here is to get the symptom story first, then the personal context, and then the emotional context. And again, to do this all in a patient-centered way using focusing and non-focusing open-ended skills. So we'll start with the symptom story, which is on your card here. Here you're eliciting a description of symptoms, and you're going to use the echoing, requests, and summarizing skills we talked about. After that's been described, then you are going to move on to get the personal context of that specific symptom. So how is this affecting your life is really kind of the crux of all of this. And here you're going to use the same focused open-ended skills. Finally, we move on to the emotional context where we're developing an emotional focus, and we're using those emotion-seeking skills that we just went through in great detail a couple slides ago. Impact, belief, trigger. Does that all sound familiar? Okay. And then finally, using nurse to address the emotions. And so the patient will feel heard, understood, and the patient-doctor relationship will actually deepen and strengthen. So at this point, we need to transition to the middle part of the interview where we actually get closed-ended, and we ask all the questions that have been on our mind. But before we get there, we need to summarize what we've heard. So I heard that you have these headaches and you feel that they may be connected to the stress in your marriage, and you have some nausea accompanying them. Then you check the accuracy. Is that the gist of it? Did I understand correctly? Then you need to indicate that both the content and style of the inquiry will change. And this is essential because if you don't do this, and you then transition into a closed-ended style, which you'll do, then the patient will be completely confused, and I've experienced it the hard way. So you basically want to say something like, if it's okay with you, having heard your entire story at this point in great detail, I'd like to now ask you some specific questions that I ask every patient on my regular visits with them who have headaches or arguments with their partner. And then you continue with the middle part of the interview. And so the middle part of the interview is the stuff that we all learned in medical school. It's basically the nuts and bolts of taking a thorough history and physical, but essentially here, you want to be eliciting the 7 characteristics of a symptom, and that's basically the crux of it.
So it sounds like the belly pain and the refill of the ibuprofen are the 2 big things on your agenda today.
That's right.
So which do you want to talk about first?
Definitely the belly pain.
Okay. Well, what I'd like you to do is sort of take me back to the beginning and tell me all about it and bring me up to today.
Sure. Well, about 2 days ago, actually exactly 2 mornings ago, I woke up with this really unusual pain that I've never had before, right about here. And it's just been there and awful ever since. Yeah, I've never had anything like this before. It's making me feel like I don't want to eat, and and it's just right here, this pain.
So it's right there.
Yeah.
Tell me more about the pain.
Well, it's burning. I've never felt like this. So I'm having a hard time finding the words to describe it, but I don't feel like eating. I feel a little bit nauseous. It's been 2 days now since I've really had anything, so I'm starting to I know I'm getting dehydrated. I did have, now that I'm thinking about it, one bout of diarrhea a couple of days ago, which is also not normal for me.
Okay. So you've had 2 days of pretty sudden onset.
Yeah, I woke
of
up with it.
Belly pain right here in this sort of upper center, burning, never had it before, and you had a little diarrhea with it also.
That's right.
Okay. Well, what else can you tell me about it?
Well, I guess that's about it in terms of what I'm feeling here. But the night before, I guess I should tell you about, was a little bit of an unusual night for me. This is actually a very exciting time for me. I just got a job after I'd been employed for about 9 months, which is why you haven't seen me here before.
Gotcha.
And,
well, congratulations.
And my friends took me out to celebrate. So,
Excellent.
it was a bit of a different night for me because I normally wouldn't have been doing that. And then I woke up the next morning, So
you went out to celebrate the night before?
Yeah, we went out to a Mexican restaurant. I don't typically eat spicy foods, so I don't know if it's that. They also bought me a couple of drinks, and I don't usually drink, so I don't know if it's that. But we were out late, and then I woke up in the morning with this pain.
Yeah. Wow. So you got this pain, kind of started with this celebration. You got a new job, and now you've got this.
Yeah.
So how's this for you? I mean, emotionally.
Well, honestly, I'm really scared. Actually, it's been a long time coming. I've been looking for work for months, and I'm supposed to start next week, and so I'm actually quite worried that I'm not going to call out my first day of work, and so I'm really worried that this is going to affect me. So I really am hoping that you can help me figure out what's going on and make me better.
Well, absolutely. What I'm hearing is that you're scared because this is not coming at a good time for you. You don't want to lose this new job. I can sure understand why that would be scary for you. Listen, I'm really glad you came in today, and I'm going to work with you. We're going to get to the bottom of this together.
Great, I'd appreciate that.
Yep, my pleasure. If it's okay with you, I'd like to shift gears now, because what I want to do is ask you a bunch of questions, try to figure out what's going on with this belly pain and diarrhea, and then I'll do an exam. And as I mentioned, I'll jump out, talk to my preceptor, and be back. Does that sound okay?
That's great, yeah.
Great. So let me ask you first, have you passed any blood from below in your bowel movements?
No, not that I noticed. But actually, other than that diarrhea 2 days ago, I haven't gone since
You
then.
haven't gone, okay. Any nausea?
I had some nausea.
And I'm going to time out there because now I'm going to ask about fever and anything else to make me think. And I'm also going to ask him about that ibuprofen and whether he's been taking a lot of that too. But that's that. Yeah. Lectures are great, but they don't change behaviors. What we did with you guys in the workshop was give you the chance to begin to change behaviors. But to interview a patient in a patient-centered style is really a little too tricky to just leave to one workshop. So in order to really learn this, what I want you to do is put the pocket card in your white coat, and for the next week or two, whenever you see a patient, whether it's consult, in the ER, up on the wards, in clinic, pull it out of your pocket and use it as a crib sheet. And I promise you, if you really commit to that and work with it, and it'll feel like a struggle, right? You're going to feel like a first-year medical student for a little while because you already have a style, and this is trying to add some new tools in your toolbox. But if you do this for a week and a half to 2 weeks, you're going to be able to keep the card in your pocket after that, and this model will become your own. I'll leave the last word to the theologian Henry Nouwen, who wrote that anyone who willingly enters into the pain of the stranger is truly a remarkable person. on behalf of the co-facilitators who facilitated the breakout groups, and Sheira Schlair, who did all the work in getting us organized. I want to thank you all. Thanks so much.